What is up, Sleep Tribe? Welcome to a brand new episode of the Healthy Sleep Revolution podcast. As always, I am your host, Dr. Meghna Dasani. But today, you guys get to listen to an incredible human that I have in my life. And I don't talk to him often enough, but I really think I should. But I'm excited to have him on the show, Dr. Taher Dhoon. He is an incredible dentist. I know if I wanted one, I would find myself flying over to Colorado to his practice. I've been there. I've seen how he functions. And he is a prime example of what I'm always talking to, not just the doctors that I train and mentor, but also to all of you that listen in every single day. How what we do in dentistry, and not just related to sleep, is all tied in because we are treating the person, how everything is interconnected and interrelated. So before I go into too many details, welcome, Taher. It's always a pleasure to see you, my friend.
Hey, thanks so much for having me. I'm super excited about doing this recording with you.
And for those listening in, Dr. Dhoon practices in Colorado, and a large portion of his practice, or dare I even say most of what you do, is related to implants. He has one of the nicest surgical training centers that I have been to, and I've been to quite a few. Just how he approaches things is incredible. So Taher, talk to us about how did you get into sleep? Like, you do surgical stuff, blood and gore, and giving people their teeth back, and not gore. It's amazing what he does. He gives people their smiles back, literally their lives back. How did you figure out that sleep was an important part of this?
Yeah, and I appreciate you tying it to surgery because in the beginning, it was all about the surgery and it was doing these reconstructive procedures and giving people the prosthetics back. What I started to notice, a lot of people were breaking their prosthetics, or we'd give them their prosthetics and they'd say, hey, I'm waking up more rested because we've supported the facial structures and opened the VDO and the vertical dimension of occlusion and put their face back to the proper dimensions that it should have been. And so from that perspective, it got me thinking about like why certain people improve, why certain people get worse, why are they having more energy just from getting this done? Was it the lack of infection? Was it, the teeth? Was it everything? And then we started to test people for sleep. And then I found there's a huge link between patients who are in a terminal dentition who need reconstructive procedures and the amount of those patients who have a moderate or severe form of apnea. I mean, it's almost like 80% of the patients in a terminal dentition have a form of a sleep disturbance occurring. So I just was super intrigued by it. And then we started finding out where we put the teeth. Are we trapping the tongue? Are we, supporting the cheeks and face appropriately? And as we improve the cosmetic profile of people, that their numbers on their sleep scores were improving as well. It was just interesting how the human body is put together in a way to help us be the best version of ourselves. And then if we lose that over years of whatever may have caused it, that we actually don't breathe better. As a result too. So it's been an intriguing journey.
Yeah, let's dive into it because, our listeners, of course, we tell dentists don't listen in. This is for patients. Everybody wants to listen in, but we also have a highly educated group of listeners that are really, really into their health and how every aspect of what we do impacts their sleep. So let's dive a little bit into this. What was it that you saw, or what started to click for you? So for our listeners, terminal dentition is when we have teeth that are failing, right? A person that, for whatever reason, cracked teeth, broken teeth, decay, periodontal disease, end up losing their teeth, or it's best for them to have all of that gone. And Dr. Dhoon goes in and reconstructs everything with implants and prosthetics as the teeth that go in, the replacements. So let's talk about why did you notice that happening? You kind of touched upon it, teeth, lip support and all of that, but could you dive in?
Yeah. So initially, if someone is in a terminal dentition, if they're losing their teeth, I don't always want to just say, hey, let's fix the problem. Let's go upstream and let's diagnose what got you here. And it could take a decade. It could take 3 decades. It could be, 50 years of damages that have occurred. But let's go upstream and try to determine what's happened so we can fix it. But for the next 30 years, we're not subjecting you to more failure. Because I'm in a position now where I'm having other dentists send me their cases that are failing, and then I have to go back in and repair them. And, it's 10 times harder to repair a case that's gone south. So it's like, okay, well, what's happened upstream. So number one, if people are grinding their teeth, it's a death sentence to the tooth. I mean, it just depends on the force factors. Consider it this way. The muscles are responsible for the forces exerted into the teeth, and the teeth are just load bearing. And then it's the quality of the bone, which is the foundation. Is it like styrofoam, or is it like balsa wood, which is that pine wood derby material, or is it like cedar wood? And then, if the patient's not breathing appropriately, is the lower jaw grinding forward to open the airway? Because as the lower jaw moves forward at night, it's the body's way of trying to open that airway. Well, and how much torque is being exerted into the teeth? And then one of two or three things happen, right? The teeth wear down and the bone will stand proud, or the bone starts to give and the teeth just become loose, or both happen, and then at that point we have to assess the patient and say, okay, now how do we fix this, and how do we prevent this from happening to the implants? Because I equate teeth to like jumping on a trampoline. You can move a tooth and you can grind into a tooth and there's mobility in the tooth, but grinding into implants is like jumping on cinder blocks. And so if we don't fix the problem upstream, they're going to wash out all the implants and have catastrophic failure and then find themselves in a reparative mode. So that's how the force factor component comes into it. And we've also, used Botox into the masseter muscles, which are kind of like at the chin and kind of go up to around the ear, and the temporalis muscles that are, those tension headache type of thing when you grab the side of your head and you're like, okay, I'm getting a tension headache. So we're doing Botox in those muscles because those muscles are responsible for opening and closing the mouth. But yeah, it's always multifactorial in how this approaches. And then you mentioned something about the face support and lip support. And it's like, well, people come in without teeth. Well, the teeth support our facial dimensions. So if they're starting to get some wrinkles or they're starting to, have that kind of like sunken in look and they're losing teeth, sometimes it's teeth, sometimes it's other things, but sometimes it's teeth. We did this surgery on this patient named Sandra, and she had her upper teeth were good, but they were just all loose. And then we take all her teeth out, and all of a sudden you see the smoker's line that are occurring around her lip. And we give her her first set of teeth that come out of a 3D printer, and we give it to her, and they're not far out enough and not long enough. So it looks like she would need Botox and filler. Well, all we do is we redesign the teeth to be further out, further down, and guess what? We've supported the face appropriately. Cosmetically, we achieved what she wanted. And then all those smoker lines were gone too. So sometimes it's supporting of the facial structures that give you what a plastic surgeon might otherwise have to come in and do, and maybe it's just teeth.
Yeah. So what do these conversations look like when you have a patient? Say I'm a patient, walks into your office, and I know I need implants. I've fought periodontal disease all my life. My teeth are failing. What does that conversation look like? What does that evaluation look like at your end? But what am I going to hear as a patient as well?
Yeah, I think initially, what I found over the years of doing this, and now I have hundreds, if not maybe 1,000 patients with this procedure done in the practice. It's a very vulnerable conversation that people are having, and they'll open up about things that they have that they're embarrassed about or there's shame associated with. And you have to let them know that, like, hey, you're not alone in this. Like, we just don't see people out there with bad teeth as often as they present because they're just not smiling. So we just confuse them as unhappy people. And I think what people need to know at the end of the day is that they're not alone. That's like just a human nature connection thing that occurs is to be heard and to be validated in that experience and understand that, like, hey, there's a lot of people out there who are in this situation for various reasons. And then we get to the point of like, okay, well, hey, are you like, do you know what this is going to entail? Like, some of this might be a little bit difficult. You might be sore. Like, are we doing this for the right reason? Do you actually need to do this? Can you save teeth, right? I'm a dentist. Saving teeth is in my DNA. So if they come in and this problem can be solved non-surgically, like I'm always going to recommend a non-surgical approach. So it's determining that aspect of it. And then for me, I've done this so much that I can see the final product. Like as they're talking to me, I'm getting excited, but I'm trying to just help educate them through the process of, this is what it's going to take to get there. And realistically speaking, I think there's a lot of false advertising out there where people think they can get it done in a day. And I finished this guy's case yesterday and he wasn't complex at all. It just his schedule, my schedule, whatever was happening. It took a year, and it took him a year to get his finals, and he was super happy with it, but he nitpicked everything along the way, which then adds time to the process. And it's not that nitpicking is wrong. It just means it takes longer to get there. I'm going to deliver at whatever level they need to get cosmetically, but it can't be done in a day. You can get your temporaries done in a day, but the finals, when everything is said and done and we're tying a nice little bow around this, I mean, it could take time for sure. So it's just managing expectations is also part of my job, is to look into the crystal ball and say, hey, here's all the obstacles I can see happening based on your med history, how you're presenting, your expectations. Are your expectations kind of meeting up with what we can do with modern day dentistry, or do we have to kind of taper your wish list to bring it down to a more realistic outcome?
Where does sleep tie into this conversation for you?
Yeah, and I'm glad you brought this up, because every patient gets an estimate for a sleep appliance now in my practice who is getting a reconstructive procedure, because at the end of the day, they need to protect their teeth and they need to protect their implants. And they also now need to protect their airway. I mean, so we factor in that cost no matter what. And then as I take them through, I'll do a preliminary sleep test to see where they are when they came in for their consultation. And then we'll get a post-surgical sleep test, because now we've given them teeth back. We've maybe changed the dynamics of the airway ever so slightly. So we have to get another sleep test to get a new baseline of where they are. And then if the apnea is still present, or if it's got worse, right, which is rare, but I've seen it like once. But if the apnea is still present, then I give them options. If they're severe, we talk about, hey, go see your physician. Let's take you through the proper course. And if they're mild or moderate, I'm like, okay, well, now the guard selection, the night guard, the occlusal appliance we're going to make you, that selection is going to be a sleep appliance. Well, and guess what? We've already factored that into your overall payment. So now I don't have to ask them for more money later. I'd always rather write them the check and say, hey, guess what? There's no apnea. Great. Here's a check. You can use it towards your maintenance, or you can just take it. So that's what we do with the sleep component when it comes to reconstructive patients, is because it presents at such a high incidence that we're just assuming everyone has it at this point.
Yeah, I love that, because that's what I tell my patients too. I'm going to assume you have it until it's proven that you don't. At least that way I know we're not missing anything. But I love that you are factoring it into your treatment as opposed to nickel and diming your patients. I can't imagine not seeing a difference, or at least you being, oh, this is so exciting. I'd liken it to playing God in a good way, because you get to control where the teeth go. You get to control the position of everything within certain parameters, you're not going to. Do you ever go back and try to change that? You have your initial sleep study with whatever the numbers may come back with, and you put them in that temporary appliance, do the post-surgical study, and do those results ever change within limits, how or where you set the teeth for the final ones?
From a way to quantify it, I would say if I've constricted the arch too much. So the patient won't say, hey, I'm more tired, but they'll say, hey, when I talk, my tongue doesn't feel like it has enough space. And then immediately I know that I've constricted them too much, and I have to expand everything to create space for their tongue. Because sometimes the phonetics is the canary in the coal mine. You've trapped the tongue so you can't pronounce certain syllables. Well, guess what you've done at night? You've trapped the tongue so it's not getting out of the airway. So that's kind of, for me, the indicator. But as soon as we expand and create more space for the tongue, we are seeing a change within the patient. In some patients, and it's usually the patient with a big tongue with a Mallampati 3 or 4, where that tongue just needs out, and you just have to create more space for them.
Yeah, and I can imagine building up the vertigo too just supports everything back there so much better, as opposed to the tissue just being able to flop back when the patients don't have those back molars that are in the best of health as we ideally want it to be. So that's exciting. At what stage do these patients get, do you put them in a temporary sleep appliance, or what is your protocol for that?
I don't put them in a temporary sleep appliance, just strictly because we change prosthetics so often. The benefit of the 3D printers is that we can print it out in like 45 minutes, and we're not going back and forth with the labs, and the designs can be done super quick. The negative of it is the strength and rigidity of the material has not got to the point where patients aren't going to break it, especially apneic patients, because when they desaturate, they clench into it. So we make them a small little quick splint guard, is basically an anterior discluder. And that kind of opens the video ever so slightly as well. And it just keeps the posterior teeth out of contact so then the firing of the muscles when the back teeth touch is 100%. When it's only the front teeth, and we can equate it to maybe 66%. So from that perspective, we're just protecting the prosthetics surgically, because I'm more invested in them healing surgically and not having to go in for a secondary surgery to repair it than I am to get them a temporary guard that will continuously have to switch as they break prosthetics. So as soon as in my practice, as soon as they get their final upper and lower zirconia, they're getting their upper lower scan with the George gauge at the settings that you taught us how to do, and then they're sending out for I like the Easy Blue Plus for my full arch cases versus any other company. It doesn't mean any other company is right or wrong. It's just what works better in my hands.
Absolutely. I say that too. It's what works in my hands may work differently in yours. Do you 3D print your sleep appliances? Have you tried that, considered that?
I do not. And the reason why is I was told that you need to have some approvals to be able to actually issue it. And medical legally speaking, I just don't want to get into a place where, hey, it's like you're unqualified to do this. So we do own our own lab. We do mill and print and everything in-house. And I just don't want to deal with that. So for me, when we go through it, I'll get them an actual FDA approved appliance that's all within standing. I treat treating medical stuff like I treat like taxes. It's like just very, keep it very simple and honest.
This is what I love about you. I mean, you're over here playing God, giving people their smiles back, their lives back in a good way, but yet you're like, I'm going to do it the right way, because at the end of the day, I want to be able to sleep and I want to know my patients are taken care of. So I love that. I love that. I know there's a little bit of a personal story with regards to sleep as well. Dare we go into that?
Oh, absolutely. I mean, it's generational for me.
Yeah, let's dig into that. Tell me.
Yeah, so my father has it. I have it. My son has it. And so when my father dropped me off at dental school, it's been like 15 years now, but on the flight back, I mean, he didn't throw the clot on the flight. I'm assuming it's when he stood up and got off the flight that he threw the clot. But he has a PFO, which is a patent foraminal valley, which is basically a hole in between the atria of the heart. And so when it goes through one atria and it goes through the lungs, it filters some clots out. And that's the benefit of the vasculature going that route. So when you have this PFO and the clot can go through, then it gets into the arterial system, and then that's when it can be dangerous. And so he threw a clot. My mom's a nurse. She's retired now, but she was a nurse at the time. Picked him up, figured it out, got him to the airport. And he had to relearn how to talk. He had to relearn how to walk. I mean, it took him like a year to get back to it. And I would say he's had a very good recovery, but just in general, I mean, he'll search for words sometimes, and maybe that's age right now, maybe that's part stroke, but either way, it was difficult for us to see happen. And it's difficult for any family member to see that. And then secondarily, and then he had a heart attack a little early, and, at least he had the heart attack next to the grocery store next to the hospital. And so they got him taken care of. I mean, he has severe apnea. He rumbles the room when you're with him. No one sleeps on vacation if you're sharing a room, because he's just so loud. And so finally, he's wearing the CPAP, and, he's doing better, and you can just, it's obvious. And then it helps that, my mom's a nurse, my brother's an anesthesiologist, I'm a dentist who understands sleep. And then, flip side, I have moderate apnea. I've been talking about sleep tests with patients for a very long time. And I took a test about 8 years ago, and I had no apnea, and I've always had trouble sleeping. I took trazodone one time to try to sleep better, and then I just wake up groggy and not sharp. So I was like, all right, whatever. Or if I would drink, I'd wake up with horrible hangovers. And what's the interesting thing that happened is if I drink now and I wear my appliance, I actually am not as hungover. So like part of waking up after not breathing all night is a really bad hangover type of sensation. And so I have moderate apnea now. So I wear the appliance, or my wife gets it for me if I forget, because she knows I'm going to snore next to her. And then she gets all the negative effects of a husband who snores. And then coupled it into my oldest. I mean, all my kids had their tongue tie release. My first had latching issues in the very beginning. It was our first kid, so we're like, why is this kid not eating? He's starving as a newborn. And we were like so worried in the hospital. And one of the nurses basically said, oh, your kid is starving to us. And it's like, we're new parents, and we took it so personally. and they just don't know how to explain like properly, like, hey, you just have to clip a little tissue in a muscle attachment. And guess what? We started, we did that at day 4, and it wasn't immediate because he was sore, but it was a pretty immediate turnaround for the context. And so we were attuned to it for the other 2 kids. It seems like it's my fault because I had my tongue tie released also. So like the apnea, the tongue tie is
It always is,
genetically.
just for the record.
Yeah.
Because your wife is perfect. So I've met her. She's perfect.
She really is. She's behind plexiglass, just this perfect work of art. And so my kid, and he's grinding his teeth and he's snoring as a kid, and he has bags under his eyes, and he's a really smart kid, and he's just exhausted. And so I sent you all his records. We got all the records, and we got him expanded, and he still grinds his teeth every once in a while, but like the snoring is like next to none unless he's like sick or, he has like some kind of whatever thing that all the kids are getting these days. But yeah, his snoring is like next to gone. The bags under his eyes are a little bit, or they're not prominent because we've expanded the maxilla or the upper arch, and then the roof of the mouth is the floor of the nose. And this is me saying to you what you've told me through the course. And then it's supporting the maxillary facial structures. And it's just really cool to see his like facial changes in the pictures too. And part of his growth and development, and part of it is expansion for sure. And now we're just waiting for his lower jaw to catch up. I may have to expand his lower jaw just to prevent, issues with him being class 2 or retrognathic or underdeveloped lower jaw in the future from an orthodontic perspective. But he's doing better. And so,
when we jump off the call, let's talk about getting him into a functional appliance to move that lower jaw forward. We'll chat. But this is great. I love that, you took the initiative to actually figure out what's going on with them, considering all of the family history and just giving them a solid start with regards to their airway. Do you screen and treat kids in the practice, or do your associates do it, or are you mainly an adult practice?
We're mainly an adult practice. Now I do orthodontics as well. So I'm screening all the kids of the practice. Just from a volume perspective, we're more known for surgery than pediatrics and ortho. But regardless, I do a lot of screening. I am training my associate currently on what to look for. And we have the sleep rings for diagnostics, and we're doing itero scans and measurements. We're looking at, mamopati and tonsils and just in general, tongue ties and all that. I haven't got into tongue tie releases and getting trained yet to do that procedure, but that's like the next evolution of how I'm going to incorporate this. Because I think at the end of the day, what lights me up, what really kind of gives me purpose is I think I gravitated towards these reconstructive surgeries because it's like immediate impact, right? It's huge for the patient. Well, guess what I can do now? I can give people back their vitality and their energy, and the way they show up. If you're exhausted, how you show up versus how you show up when you're well rested. I have a buddy who's my age, and has an Inspire at this point, and he got 2. And he still struggles with sleep because the Inspire's not cutting it all the way. But there was like a 2-day stretch. He got sleep for 2 days, and he like cried out of happiness because he's like, I've been exhausted for so long. I mean, it's so important. And so, yeah, I'm really excited about adding this to the mix because it's such a impactful thing you can give to someone.
Yeah, for sure. It's like I tell patients, what you have is your normal. And when it's like giving our kids sugar for the first time, right? You've gotten hooked onto the feeling of, oh my gosh, is this what it's supposed to feel like? And I hear this a lot when I release tongue ties as well in slightly older kids. They're like, I didn't know I'm supposed to be able to move my tongue this way. And a much smaller way as to how you're changing lives, but I completely get it. I mean, I get the feeling of patients actually, like, I've seen your videos, from cases that you've done. And it's like these patients just can't believe it's them. And it's what they've always wanted. So that's amazing. How can our listeners find you?
You can reach out to me on social, right? Taher Dhoon, Dhoon. I think I'm the only Taher Dhoon in the world. So if you find me, that's going to be me. And social works, or you can just email me at tdhoon. So it's tdhoon@gmail.com. So Tango, Delta, Henry, Oscar, Nancy @gmail. And then, I'm here to help in whatever way possible. I mean, if you're trying to do a startup or acquisition, Dr. Green and myself have Yeah.
Yeah, I wanted to dive into that for our dentists that do listen in.
Yeah.
I know you coach so many of us on implants. So I want to jump into Colorado Surgical Institute as well as your startup. So let's dive in for our dentists that are listening in.
Yeah. Yeah. So, I mean, Chris Green and myself, we wrote a book about startups and acquisitions. And it was cool. We did a seminar in Houston actually pretty recently. And it was nice because one of the couples we have helped to get their practice going, this guy named Freddie, husband, wife, Freddie got up on stage and started talking to people. And he was like, man, like you guys gave me the confidence to do this. Like I was too scared to get out there and go be a practice owner and figure out contractors and architects and plumbing and electrical and all this stuff on top of just being a dentist and doing that well. And it was just really cool because then after we finished the course, another couple who were attendees came up and they came up and said, hey, that's exactly our scenario. We're just really nervous about getting off the sidelines and putting ourselves out there. Because I've actually been broke. The first startup I was doing, 7 years ago, crashed and burned, and I lost everything. And I had to go to my wife and tell her, hey, I made some business decision errors here that may have set us back catastrophically. Thank God that didn't happen. But through the Practice Launchpad, Chris and myself were able to help younger docs like navigate the waters on how to get into practice ownership. And then we help teach the business of dentistry as well. And then Colorado Surgical Institute kind of just formed organically. I was just doing a bunch of surgeries and some dentists wanted to come watch us do our thing. So they just come into the operatory and, watch, and I'd answer questions, and then they would start bringing their own patients. And then we started traveling to them, and we just decided to start our own course. And then it just worked really, really well. And so people come to us and we train them on the patients of our practice, and I manage all the complications and post-op care afterwards. And the docs get hands-on experience because in Colorado, as well as a couple other states, you can come from another state and actually treat patients in my practice, and all the malpractice and all that other stuff is still in good standing. So you can get hands-on learning stateside versus having to go to like the Dominican Republic or Nicaragua or wherever people are going, because I did the Dominican back in the day. So yeah, those are the two projects we got going on. And currently we're building a new facility for the practice. So we're going from 6 ops into 18 ops, and that should be done by July 1st, hopefully. And it's going to be 12,000 square feet. And in the basement, we have our conference rooms and all of that. And then we'll just go upstairs and do the surgeries upstairs. Oh, and another really cool thing. This one is actually near and dear to my heart. We actually started an IV sedation course. But the reason why...
No way, what? I didn't know this.
Yeah. So it's my brother. So my brother's an anesthesiologist, and we actually got to have him come like write the curriculum, and we met in San Diego, and he recorded a bunch of stuff. And it was cool to have my buddies who we do the Colorado Surgical with meet him and be like, man, your brother's a machine. Like this guy just got up there and knocked out every take on propofol and Versed and just killed it. And so, and so we're going to start teaching IV sedation too out of Colorado Surgical Institute.
Wow. I am mind blown. I mean, I know Taher always blows me away every time I talk to him, but this is a whole different level. I'm assuming you have upcoming dates for upcoming training sessions for each of these, for your Practice Launchpad, for CSI, IV, everything.
Yeah, I would recommend to check us out on the websites. I think we'll post it in the show notes for Colorado Surgical.
Yes.
We have maybe one spot left in June.
Yeah, we'll post all of this information in the show notes. And guys, he shared his email with you guys. Just go hunt him down and bug him to get you into his courses if you haven't. I have been there, not as an attendee because I don't do surgical stuff anymore. I leave it to him, but I have seen how he runs these training sessions of his. So wow, simply amazing. As we sign off, Taher, let's jump right back into our patients and address, the people that we actually serve. That is our calling. What are your top tips for patients, be it with regards to implants, be it with regards to sleep? What is it that you wish everybody knew?
I think from a patient perspective, what you need to know is, I think the number one question I get is like, well, why are you looking at this? Like, why is my dentist doing this and not my physician? And I think from a patient perspective, there's an easier way than CPAP sometimes. And so understanding there's an avenue that's proven, that it cannot be disproven, that this is a solution, and it doesn't have to be looked at under a microscope of is there something, fishy going on around here? It's like, no, it's just like some dentists who get into sleep dabble in sleep, and some dentists who dive into sleep are doing it for like profound meaning and reasons. And to feel out that person and talk to that person and make sure that that vibe you get is there. But if it's there, just know that the therapy or the prescribed treatment is actually 100% legit. From a dentist perspective, I would say, I mean, if we look at what we can do, people don't stand up and give me a standing ovation to do a filling or a crown. It's never happened, probably never going to happen, right? But if after sleep and after reconstruction and after like they sleep better and they show up better for their family, I mean, it is impactful. And like men will come and hug me and they will crack my back because they're squeezing me too tight because they are just like overcome with like emotion. And it's fulfilled me. It's made me feel whole to incorporate these things into the practice.
Wow. Yes, for sure. You can tell he's certainly given some thought to all of this. It definitely, we do change lives in different ways. Well, thank you so much for taking the time to come out and chat with me today. I know you're super busy. As always, it's a pleasure to have you on, my friend. And for those listening in, as I said earlier, we will have all of Dr. Dhoon's contact information, websites, social media handles, everything in the show notes. So reach out to him. Docs, if you're looking to get trained, he is your guy, I promise you. As always, share this episode with somebody that you know could benefit from it, be it a loved one, be it a colleague. And I will see everybody next time. Thank you, Taher.
Thank you.